Well, good morning, everyone, and good afternoon and good evening to those over in Israel. It's a pleasure to be back with you again. One of my favorite parts of my career has been working with Haruv and working with Asher from the early days when it was just a vision, and look how far it's come. It's really been a joy. I owe a lot of appreciation to Haruv for helping me with my philosophy and my orientation around prevention of mental illness and substance abuse. It really was learning from the systems in Israel and how Israel is probably the world's leader in looking at PTSD and trying to prevent it before it happens with early intervention. And so a lot of my flavoring of the work that I'm doing now has been very much influenced by what I learned from Asher and Dr. Fortuna Ben Arush at Hebrew University. It's been just a joy. What we're going to talk about today is a little bit different than what Michael Baxter talked about earlier when he talked about kind of how do we deal with the stress of the pandemic. And what I'm going to talk about is long-term. How do we develop better systems to take care of our clinicians? And a lot of the data here is off of physicians, but I use the word clinician whenever I can because I think what we've learned from clinician burnout and depression and suicide can translate to all of us as clinicians, and I think it's very pertinent. What you'll also see is that there are certain organizations, certain health systems that are very much leading the way in redesigning the system for clinician well-being rather than just expecting the clinician themselves to be resilient and tough and get through this. Instead, building better systems around those clinicians so that things work better for them. So let's go to the next slide. So this is part 2 of a 3-part series of lectures that I've been given on this. And for this one, the first one was really on the acute stuff, the acute things as far as dealing with stress. This is on the long-term strategies for building better systems of support. And then the last one that lecture that I'm building is on the mental health aspects of our community during a pandemic. What we'll talk about today is the state of mental health among U.S. clinicians prior to COVID-19, and then we'll talk about the additional burdens of COVID-19, and then we'll move into the most important part, which is looking at some of the role model health systems that are improving clinician well-being through a systems approach rather than just resiliency alone. Let's go to the next slide. A nice way to think about this is with Abraham Maslow, where you have to take care of basics, and then you move up in level of complexity and sophistication as far as who we are, as far as selves. And then lastly, when we're working really at the top of our license, when we're working for the benefit of others. And when we start thinking about clinician well-being programs, we have to take care of the basics, and that's some of the individual work and coaching and confidential clinics and fitness and sleep. But there's the group work as well. How do we work as far as groups together? And this is where reflection and resiliency training and mindfulness can be helpful. And then lastly, how is the system that you're working in paying attention to your needs and making the work environment work much better for you? Let's go to the next slide. So let's talk a little bit about the state of clinician mental health. And as I said before, a lot of this is physician oriented, but I do think it translates to the broader group of clinicians that we're working with here. Next slide. There were a lot of pressures on clinicians before COVID-19 hit. A lot of pressure on productivity and value-based payments, working with the electronic medical record that's at you 24 hours a day and now allows patients to interact with you on a very regular basis beyond the 8 to 5 work schedule. Clinicians are rated, sometimes unfairly, and social media can publicly complain about a patient. In the arena of marijuana here in the U.S. and in the arena of opioids, if a physician is tough and restrictive on supporting marijuana or prescribing opioids, sometimes patients can come back and be just very, very harsh in the social media platforms as far as that physician. Physicians are put up against rankings. There is liability. all have to maintain our credentials and our licenses and our privileges. And then we are dealing with clinician shortages, and I'll show you some data on that. And we're dealing with our work changing dramatically with automation, and we're dealing with artificial intelligence. And in fact, there is an algorithm system being developed that is matching psychiatrists against computers as far as diagnosing psychiatric disorders. And the artificial intelligence algorithms are about 80% accurate now. So what that does is pushes us all to be able to and need to be working at the top of our license, whereas technology can help with the more simple things. And what we'll see is all of us taking care of more complex sets of patients within our set of skills. I start a new job on Monday. I'll be the Senior Associate Dean at the University of Iowa Healthcare. And my work will be as the psychiatrist in the intensive care units. And these are very complicated patients. I'll be taking care of COVID patients. Those COVID patients experience a lot of ICU delirium. The virus itself is toxic to the brain, but also being in the ICU for a long time, being on a ventilator for a long time is very hard. So a lot of clinical pressures of working at the very top of your license at all times. Next slide. The University of Michigan did a survey of their 1,500 physicians, and what they found out is those physicians who had 80% of their time dedicated to clinical load, 60% of them reported burnout, whereas those that were more of a researcher and less clinical load, only 30% burnout. The group that was at the highest risk for struggling with this was 49 to 55 years old. Many of them were having to do the electronic medical record at home. 50% reported that they didn't sleep well, and 42% said that the workplace they're working, and this is University of Michigan healthcare, it's a top of the line health system and hospital, but they reported the work as hectic and chaotic. But they also scored 75% on in the high area of resilience. And we as clinicians are resilient. We know what we signed up for, but some of the pressures right now are extraordinary. And there is ways that we can pay attention to those and actually design things around our clinicians so that we can do better and it doesn't feel as hectic and chaotic. Next slide. On that same study, 14% of the faculty, physicians, reported moderate to severe clinical depression. That's a pretty high number. And of that group, only 50% was willing to seek help. And they were not willing to seek help in part because of stigma, but also confidentiality and licensing reasons. Many of us, when we re-up for our license, have to check a box around whether we've been under the care of a mental health professional for a psychiatric condition. 25% of the residents at Michigan reported and met criteria for clinical depression, and 50% of the resident physicians endorsed burnout as well. So this is a top of the line health system, but I do believe what Michigan found is probably indicative of what's happening across the globe, actually, as far as the stress in delivering healthcare. Next slide. The cost of physician burnout is estimated to be $3.4 billion a year, according to Mayo. And for the Mayo system, it's $2.5 million a year in lost productivity. So there is a financial case to be able to be made to those that are directing the finances of an organization, because burnout does cost productivity. And the ability to pay attention to this does take resources, but I think investments actually save money in the long run for an organization if leadership can see that. Next slide. I myself was a victim of this. When I was a university president for 12 years, I was averaging about 80 hours a week of work, 7 days a week. Lots and lots and lots of travel. And although I thought I was taking care of myself health-wise, I was ignoring what was chronic pancreatitis. And I had emergency surgery in January, And I woke up from that surgery thinking, I just cannot push myself this hard, this much, this fast for this long anymore. So rather than calling it burnout, I called it clinical burn up. I just was burning up my body working so hard on this. And I think it's something that all of us need to pay attention to as well. And that's Ferris Bueller on the left. That's my small dog, and that's Loyal Dog on the right. And they're actually watching below right now as we speak. And they knew I was sick, and they were following me around everywhere I went. But I fully recovered. Things are great. Just ran 5 miles, so I'm happy. Let's next slide. Across the world, across the country, we're seeing that the NIH and SAMHSA have concerns regarding the rapid increase in mental illness on college campuses as well. And I'm part of a study group from the National Academies of Science, Engineering, and Medicine on mental health, substance abuse, and well-being in higher education. And one of our key findings is that clinical depression and clinical anxiety each have doubled in their percentages on college campuses in the past decade. So we're seeing an increase in mental distress and in diagnosable psychiatric disorders, even among our college students as well, and it's increasing. Next slide. And 40% of college students now are seeking treatment from their universities, and they require medication. So it's not stress alone related issues. These are diagnosable and needing medication level psychiatric conditions. And what we're also finding is that the larger universities struggle to provide adequate access to care for their college students. So we're seeing mental illness on the rise across the country among college students. And let's go to the next slide. And we're seeing it in our general population. This is from the National Academy of Sciences, and they put out a report that showed that mortality across the world in general was improving, except in the United States. And that red line on the left is US white males age 45 to 55. And what we're seeing is their mortality is worsening. And on the right, the causes of that mortality among this group are pretty identifiable. We see that it's due to drug and alcohol overdoses, to suicide, and chronic liver disease, which is primarily alcohol-related liver disease or cirrhosis. So we're seeing segments of our society that are really struggling. We know the college student segment of society is struggling. We know the middle-aged US males are struggling significantly as well. Next slide. Next slide, yeah. We've also seen that there's a huge amount of back one. There we go. Mary Hawkins, which is a physician recruiting firm, said that they have never seen such a demand for psychiatrists, and they expect in the US that we'll be short 16,000 psychiatrists. And one of the things I noticed when I was dean of the medical school is that the pressure on the child psychiatrist is probably even greater, because the payment for child psychiatry services is not great. The amount of time it takes to do child psychiatry work with a family is significant. Child psychiatrists are taking care of the child, but also the parents and the family and the siblings as well. So it's complex work, and the system doesn't support them very well. And I think Sarah Passmore and Michael Baxter are probably saying, you bet, that's exactly what's happening. And when we look at domestic violence and child abuse and child maltreatment, those issues are even probably more significant, as far as not enough time and not enough payment for the level of services that those psychiatrists need to be able to provide to those families. Next slide. When you look at physician clinical depression, we notice that it begins in medical school. 27% of medical students report depressive symptoms, but very few of them seek help. And up to 24% actually have thoughts of suicide. It continues as resident physicians. 28% of resident physicians have major depressive episodes during their training, and 23% of them have experienced suicidal thought. And it still lasts into physicians, practicing physicians. About 12% have clinical depression, and 19% of females have clinical depression. And the females struggle more than the males with this, as we'll see in just a minute as well. Next slide. And suicide is one of the only causes of early death that is higher among physicians than the general population. And part of that is that the system of support puts barriers in the way of those clinicians getting help. And I think we can say the same thing for psychologists. I think we can say the same thing for social work. I think we can say the same thing for clinical counselors as well, that the systems there's barriers there to seeking help, and in doing so really leads to burnout, depression, and suicidal thought. Next slide. Suicide rates per 100,000, general population is about 14.5. In Tulsa, it's 17.2, but physicians, it's 28 to 40 per 100,000. And so it is a significantly higher number than the general population, and I think in part due to these barriers. Next slide. It's about 300 to 400 per year are documented. The number of suicides is probably much higher. Male physician suicide risk is twice that of the general population, and female suicide risk is almost 3 times that of the general population. And clinical depression is the highest risk factor for this group as well. Physicians who did take their lives were much less likely to have accessed care as well. Next slide. At Autopsy, what they found out is that physician suicides, the blood screens looked a lot different than the general population. The general population did have oftentimes antidepressant medication in their blood, but with physicians, it was not antidepressant medications. It was benzodiazepines or barbiturates or antipsychotics, but not antidepressants. So showing again, physicians are not seeking treatment. Next slide. And then comes COVID-19. And we've all got we're interacting with society. It's the work that we do. And as much as we can, we're doing it through telehealth, but sometimes you just can't do it through telehealth. And we are concerned about infecting others with COVID-19. We're worried about ourselves being infected. This is hard work. Stamina is an issue. The decisions we have to make over these care of these patients and these families is difficult by the hour. We struggle with enough personnel protective equipment. I know a physician who was not allowed to use personal protective equipment on a patient who was suspected of having COVID. And then he himself contracted COVID and was sick for a month. And he was at home for a month, and he really, really struggled with it. And it was in part, they were trying to ration the personal protective equipment. We've done better in this country as far as access to ventilators. But we've also delayed elective procedures. And what we're seeing is those elective procedures, in some instances, were people just not coming to the emergency room for things that they needed to come to. We're seeing a huge increase in strokes and a huge increase in acute heart attacks because people with chest pain and people with some symptoms leading to a stroke are not coming to the hospital early enough. And so we're seeing the heart attack and the stroke actually occur. The rural hospitals are really struggling with this as well. Next. When the frontline workers, healthcare workers, and this is physicians, psychologists, social workers, respiratory therapists, physical therapists, those that are on the front lines, what they reported was that 75% were exhausted and a lot of mental distress, 50% had depressive symptoms, 50% had anxiety symptoms, and 33% had significant insomnia. So the stresses of caring for those with COVID-19 is having an impact on our frontline healthcare workers. And I think we will learn more and more. I think we will see more acute stress syndromes, and we will see more post-traumatic stress syndromes from our frontline workers as the months roll on. Next slide. So let's talk a little bit about well-being strategies. And this is in part some of the work that I learned from Haruv and from Asher and Dr. Fortuna Benarouche about thinking proactively and thinking about prevention ahead of time and intervening early. And so thanks to Haruv for helping me with my orientation on this. Next slide. The first thing is that we really need to be thinking a little bit more down the road as far as additional global diseases. Hopefully this pandemic will change how we think about preparing for other illnesses that are global, that occur across the world as far as prevention and monitoring and planning. We learned from the Spanish flu. It had 3 waves, and we should be right now thinking to ourselves, what can we do to prevent a second and a third wave of COVID here? We know we need to have testing available and contact tracing. We know we need to have the vaccine, the personal protective equipment, ventilators, and we know we need to have a system of healthcare that can surge capacity when needed. Right now, or back in December of 2019, it was good for a hospital to be 99% full. That meant they were working at their maximum efficiency. Every bed was being utilized. But then when you have a huge increase in the tens of hundreds of thousands of people who also need care, there's just no room in the system for that surge. And we're learning that lesson, and the ability to be able to make new beds and make temporary hospitals and temporary ventilator systems. But hopefully we can think about this long term. Next slide. One thing that what I've noticed, particularly among young clinicians, is they are really good at using technology as an aid to their well-being. And I sit down with the med students and the resident physicians and I ask, okay, what are you doing right now with your phone to make your life easier rather than more complicated as we think about the electronic medical record? And they come up with the greatest apps. I see them walking around the hospital with headphones on. And they have noise canceling headphones, and oftentimes they may be listening to the Rain app, which is a very peaceful thunderstorm in the background app, and it allows them to block out all the noises, and so they can think clearly. And it's a quite powerful tool. So the Rain app is a great one. They sit down and work with the medical informatics and coding and billing people on a regular basis so that they're doing it right. And what they've learned, and I think a lot of us have learned, is there are services out there that will help us with shopping. They will help us with laundry and groceries. And I've watched these students, they do a great job. There's one student who, or a resident physician, young faculty member, who actually outsources his PowerPoint presentations. He sends them the basic document in a Word format and then outsources the PowerPoint to India. And what he gets back is absolutely beautiful stuff. So there are some neat things happening with technology to make your life actually easier rather than more complicated. Next slide. One of the leaders in getting ahead on mental illness early intervention in health systems is Oregon. And this was prompted by a suicide they had of a female resident physician. So they put together a coaching and counseling and easy access to a psychiatrist program. It was confidential. It wasn't part of the electronic medical record. It was in an inconspicuous location. Alongside that, they built in bystander intervention trainings for other clinicians to be able to step in if they saw a clinician who wasn't doing well. A mental health first aid approach. They put together a peer-to-peer support program. And what they saw is very positive ratings by the clinicians that used these services, that it worked really well and it was protective and caring of those clinicians as far as their mental well-being. Next slide. And the next slides just show that over the years, the number of resident physicians per 100 went up significantly, up to about 25% of the resident physicians at Oregon were using the service. The slide on the right shows the number of sessions each resident needed, and this is a good thing. You see that the number of sessions is going down per resident because they're coming in earlier and their problems are being worked through with a fewer number of sessions because they're coming in earlier. Things hadn't really turned into big problems and needed a lot of sessions. Next slide. At Stanford, they really looked at clinician time and the time that they were doing extra things that really didn't get counted for as far as their academic work or their billing time. And they were able to put together a credit system in the form of house cleaning and home meals and laundry and medical education material development as a way of paying back those clinicians for putting in those extra hours. And the next slide shows that, next slide, yes, shows that the clinicians in the hospital really felt like there was an improvement in culture of the system, that there was attention to their wellness, that people now understood their professional development opportunities, and a big increase in their job satisfaction. So again, that systems approach, getting ahead of it, taking care of the whole person and intervening where they can beyond just individual resilience. Next slide. University of Colorado took a slightly different approach. They really became focused on being a great place to work, and in doing so would be one of the best health systems in America. They focused on their hospitalist team and put together teams to improve the processes of the care that they were delivering. And you'll see some really interesting projects within projects here. Next slide, go. They put together the Something Awesome program where they shared positive experiences with the team and patients. They put together collaborative case reviews that were non-punitive as far as, hey, maybe I made a mistake here. How could I do this better as far as taking care of someone? They put together above and beyond award systems. They had flash mobs if there was new systems problems that arose that they could solve the problem. And one of the most popular and successful parts of it was their incubator program, where they would take clinicians off campus and for a half day redesign how they were doing the care of others, and it was really seen as very positive. They also put together a new parents program, and that new parents program, you know, how is a very busy person, when you have a child, do you make it all work with a new child as well? And they had a great support program for that. Colorado's results, next slide, go. Big improvement in psychological safety, improvement in callousness, and improvement in burnout. So the point being here that you can design systems to support the individuals and see a big improvement in their well-being. Next slide. Mayo has done some things similar. They put together some facilitated group discussions on mindfulness, reflection, shared experience, and small group learning, and their results were very positive as well. Next slide. And what you see is an improvement in empowerment, less depersonalization, and a sense that their work is much more meaningful. And they've really expanded it to their 1,800 physicians at the Mayo program. Again, the main point being systems designed to support the individual with positive results. Next slide. Another one they did was with coaching, and again, improvements in emotional exhaustion and burnout, and improvements as well at Mayo in physician turnover, people leaving the health system. It's one of the best in the country as far as retaining workers because the way they approach the systems. Another thing that Mayo has done is they've employed engineers to help with systems efficiencies and workflow as well. Next slide. So in thinking about building a model clinician well-being program, it is similar to what Maslow said. We've got our basic needs first, and for individual clinicians, that's fitness and sleep and diet in a confidential clinic or services available to them. Then there are the psychological needs that kind of fit in between, and for us, that's the group work where we are able to reflect and support each other, attention to mindfulness and resilience, the new parents program, and technologies and apps. And then there's those broader self-actualized, where we're working for the benefit of others at the top of our license type systems. And that involves culture and well-being and prevention, utilization or time utilization, and preparing for the pandemic. And so wherever you're working right now, hopefully the leaders are thinking like that, at that individual level, the group level, and then the systems level as far as their employees that are doing such important work right now, and will need to continue to do such important work. We really don't know when we will go back to a new normal, but something different than what we're at right now, which is difficult for all of us. Next slide. So in summary, the mental health state of our U.S. physicians and clinician workforce prior to COVID-19 showed strength. and the need for significant improvements. And then we layer on top of this something we've never seen in a century here in the US, as far as the pressures and the stress and the worries and the fear and the anxiety that comes along with COVID on being a frontline worker. And as Michael Baxter talked about, there's need for individuals to work through some stress management strategies, but there's also the need for us to be working on the system level and the group level as far as supporting the person beyond what they individually can control, making sure that the system and the culture is taking care of them. And then later on, if Haruv on the couch continues, I'd be happy to come back and talk about the work that I'm working on as far as what this will mean as far as the mental health of our entire populations. We've learned this from many disasters in the past. Being from Iowa, had a farm crisis in the 1980s where there was a huge economic recession and drop in land prices, and many farmers went bankrupt, and we had a huge increase in suicides. We learned from Hurricane Katrina in New Orleans, huge increase in PTSD, depression, and suicides. We learned it in 2007 and 2008 with the Great Recession, where a huge economic decline led to a huge increase in post-traumatic stress and in depression and suicide as well. So I think COVID is not going to be, I think COVID will follow the same track, but we can learn from the past by paying attention to what we've learned from the past, and hopefully put some prevention systems in place for the long run. All right, well, that's my last slide, and I'm happy to take any questions.
Thank you, Dr. Clancy, and we will love to continue with you. Christina, and if you have questions, you can also open the mic and ask them.
Gal, we already have one question. It says, do you think there's an increase in mental illness or substance use, or more about awareness and people reaching out?
You know, it's a great question, and we asked that with our National Academy's work, and our conclusion was yes to both. There is a great improvement in recognition of previous stigma, and that stigma being able to be at least taken down a little bit. And I see that with our college students. I mean, they are willing to talk about their mental struggles in a very open way, and they've been very expecting of a university to be able to provide enough services for them. So particularly among young people, I'm seeing a totally different attitude around seeking help around mental illness. And I think we've come a long way as far as stigma. But I also think we're seeing an absolute increase in mental illnesses. And we've seen an increase in autism. We know that. We know we have an increase in bipolar disorder. And now I think with the huge amount of stress that this has put on society, we will see a big increase in post-traumatic stress from this. Some of the things that people are going through is so difficult. And we have indicators of significant increases in substance abuse. Alcohol sales are at record numbers right now. And in Oklahoma, the amount of marijuana sold over the past month was almost double what it had in previous months. So we know people are turning to substances for relief as well. I think the answer is better recognition, yes, but also an absolute increase as well. Great question.
Thank you. So the next question, do you think some of the increase in mental illness has anything to do with increase in social media?
Again, a great question. The folks at the Laureate Institute of Brain Research are looking into this very intently. And some of the results so far have been surprising. For the most part, those that are very socially isolated and dependent only on social media as a way to interact with people, that does appear to be a problem environment. But on the other hand, there are people that use social media to be social in other ways and connect with people, and let's go out and let's go have fun, and those people are actually thriving with social media. So the Laureate Institute of Brain Research is studying 9-year-olds all the way to 19. They've got about 400 of them, and they're 2 or 3 years into it now. This is called the ABCD study, Adolescent Brain Cognitive Development Study, and it's these kind of things they're looking at of how much social media, how much social interaction, how high are the ACE scores in these homes. It's the first time we've ever been able to do this long-term study with this age group to really look at that age-old question: how much of mental illness is nature and how much of mental illness is nurture or the environment? We've thought about that question for 100 years, but never have we really studied it intently and in depth like this. What Laureate has been able to do is, alongside great neuropsych testing with this, they're also doing genetic analysis, and they're also doing brain scanning on this as well. So you're going to have this bank of brain imaging and neuropsych testing and genetic testing to go alongside what environmental factors were this group of kids versus this group of kids. And I think what we'll see is that chaotic, stressful, harmful, abusive environments lead to a different brain development pattern, just like the folks with ACEs predicted it would, that the stressful, chaotic environment leads a brain to go in the direction of soothing and immediate reward and protection. And the brain that is raised in a nurturing, caring, loving environment will lead to a brain that is seeking learning and social relationships and helping of others as well. And 7 years from now, I think we'll be able to use this data to influence policy, to influence funding, just like we always hoped it would, that we can now explain to legislators and to insurance companies, nature and nurture have major factors here. And these are brain illnesses, and how you fund things and what policies we have makes a huge impact on where these kids end up as adults. Great question.
Thank you so much for your perspective. That was a really great answer. The first person who asked a question had a comment. She said, thank you. I've noticed that myself. I went back to school for another master's at UMD, and all the professors are reaching out to students more about their mental health and well-being.
Yeah. We, at the University of Tulsa, realized that our graduation rates weren't where they needed to be. And when we looked at it, it was our retention rates that from freshman to sophomore, sophomore to junior, junior to senior, we would see a percentage of students drop out. And at first, everybody thought, oh, it's just academics. People aren't able to keep up with the academic demand and they're dropping out. Maybe we just need to do some more academic tutoring services. But when we dug deeper, it was much more around the need for wraparound services. It was the need to have learning disability accommodations, the need to have mental health services, the need to pay significant attention to the sexual assault prevention. We had, if a student was sexually assaulted, there was a 90% chance they would drop out of the school. But over a 3-year period, we've been able to reverse that entirely, that if a student is sexually assaulted, now only 10% drop out. So it's attention to systems and attention to the wraparound broader aspects of really the social determinants of health are huge players in these issues. So great question.
Thank you. Right now, there aren't any more questions, but I'd like to invite people to go ahead and if you have a question, type it in the chat or open your mic and ask, and we'll just give a few minutes to see if there are any more.
Okay, so it's look like we've done.
Great.
Christina?
Yeah, I think so. If nobody else has any more questions.
I have one question.
Oh.
Go ahead.
So if you mentioned earlier in the presentation that some professionals may be deterrent to seek help due to licensure and confidentiality. With all this happening and with the increase of people trying to seek help, do you think that licensure boards would start to maybe change their policies?
I think they are. I think they finally are. And I'll use an example of what we've been able to set up with the Oklahoma State Medical Association, which kind of right next door is the Oklahoma Medical Board. And what they've allowed is essentially an EAP program for physicians that is allowed and doesn't count as seeking mental health and or seeking care from a mental health provider. And it's worked beautifully. It really has. So I think it's just starting to happen that the boards are understanding that what looked like good policy of making sure someone with mental struggles isn't taking care of patients. The result is they're still taking care of patients. They're just suffering a lot. And so let's instead flip it and get them some care. There's not much evidence that a struggling physician makes medical errors at all. They just suffer is what they do, is what we see. So I think we're starting to see changes in that. And it comes along with our society's stronger, better attention to the stigma around mental illness. When we put out our National Academy of Science, Engineering, and Medicine study results, we're in the final stages of writing, we start with stigma. And that stigma is still an issue in this country. We made progress, but the more that we pay attention to it, the better it is. In Oklahoma, it was great to see that the governor's wife, that was her first platform issue. I hope it continues as we talk about this. This year, the Tulsa World ran 10 different stories on ACEs, adverse child experiences, and really opening up to the general population the understanding of the link of environment and brain and mental illness and substance abuse and ACEs, that it's a lot more than just individuals, and it's not individuals with weaknesses. It's individuals struggling and needing help at that broader system level.
And to piggyback, on that same issue, not only mental illness, but I'm a clinical social worker, but I also think about the issue of mandate reporting and how that too may stop professionals from reaching out to seek treatment, because how that may affect them personally as well.
Yeah. So as we go forward, I think COVID is going to be an opportunity for us to be able to say, a very stressful environment leads to individuals struggling naturally. They're having a normal reaction to a very abnormal situation, but they're struggling. Now let's help them. Let's help them. Let's not penalize them for having a normal reaction to a very abnormal situation. Let's help them. Where I'm at right now, the University of Iowa, they set up a 24-hour hotline for any frontline worker, and it gets about 2 calls a day. And the calls that come in are people just desperate, in trouble right away. That's kind of like they're at their last rope. They just can't think straight. They don't know where to turn. They're in panic mode, they're in panic because of the high level of stress that has been put on them. They're not in panic because they're just not good at dealing with stress. What they're not great at is dealing with overwhelming stress. And who really is. Yeah.
Thank you. There's a comment in here from Alana. Thank you, Dr. Clancy, for your role in bringing Haruv to Tulsa. You outlined the plans on a napkin 7 years ago, and 5 years ago, the office was staffed and the first training was implemented. So thank you.
Yeah. Well, thank you, Elena. And as Lynn says, you know, I can't remember exactly how Lynn says it, but she makes it possible, but you all make it happen. So great job. Is that right? That's pretty much how she said it. Yeah. A joy to work with. A joy to work with.
We appreciate you being here. And with that, I don't believe there are any more questions right now. So if that's the case, then we can wrap this up.
Great.
Thank you, Dr. Clancy. Thank you so much. Especially, I know that you moved to Iowa, and I guess that you are so busy. So thank you for giving us your time for this important information. And we will be in touch.
I think I'm going to write a book, How to Move During a Pandemic.
Good idea.
I wouldn't do it again.
Yeah, I can imagine.
Take care, everybody.
Okay, stay safe, you all, and see some of you in the afternoon. Thank you.